I'll be just saying about white dot syndromes, how to identify and all. So, white dot syndromes are the group of the inflammatory choroidititis of unknown origin. So they can have multiple yellowish white lesions which may affect multiple layers of the retina and RP, and it can also involve the choriocapillaries. Then most commonly they have symptoms of photopsia, blurred vision, floaters, and visual field loss. And most of these cases are associated with viral prodrome. These are the various white dot syndromes what we know, like mutes, APMPP, Azure, and all. I'm not going to go one by one. I just wanted to show how to identify them, what are the differential diagnosis, with the investigations what we are going to do, like that. So just let me go to the approach of these white dot syndromes, how to differentiate. So coming to the gender this thing. So mutes, birdshot chorioretinopathy and multifocal choroiditis, these are mainly affect the females, young females. But APMPP and subcutaneous choroiditis, they don't have any gender preponderance. They can affect both males and females equally. And coming to the history, that like different white dot syndromes have a history of photopsias and they have a classical history. Like in a mutes, they will say like shimmering like photopsias they can able to see, and in the azure they will say something like light like thing photopsia is coming and it is moving in an area where there is a vision loss is there. So that type of photopsias can tell you which condition it can be. Next, most important, coming to the retinal lesions and about the size and shape of the lesions in these conditions. So first thing is the mutes, multiple evanescent white dot syndrome. Has the name only it explains, it's a evanescent, smaller, and there are multiple. And these discrete lesions are at the level of outer retina and RP and are very small of around 100 to 200 microns. APMPP, they has the name suggest again, it's a acute placoid. So these are the creamy colored placoid lesions at the level of outer retina and RP, and they are more than a zero point 0.5 disc diameter size. So acute macular neuroretinopathy, they have a typical butterfly shaped lesion which is over the post fovea. You can able to see in this enlarged picture, this is a reddish lesion, butterfly shaped lesion which you can able to identify. Azure, they have in the early stage of Azure, they may not be see any retinal changes, but in the slightly later stage or the chronic stage, you can able to see a typical altitudinal RP atrophy in the area which is affected. Multifocal choroiditis, you can able to see that they have a lesion of around 50 to 350 microns, and they may have subretinal fibrosis in the later stage. And when we see this subretinal fibrosis, along with that along with this whitish lesion, I think is something called a Shiger's line. So that means it is still active, and these requires immunosuppression. And as they get scarred, you can able to see well-defined choroidal atrophy in that area in a line. Similarly to multifocal choroiditis, if the size of the lesion it is there over the fovea, it is around 100 to 300 microns. We say it as punctate inner chorioretinopathy, and this has a high chance of choroidal neovascularization. Birdshot choroidopathy, they have a typical ovoid shaped yellowish lesion at the deep retina that radiates from the optic nerve towards the periphery. As it goes outside, the size of the lesion also becomes larger. Serpiginous choroiditis, they have very ill-defined gray-white jigsaw shape-like lesions which will progress as the day progress. And it may get atrophy, pigmented choroidal atrophy occurs as the treatment occurs. So just to show again, so mutes has 100 to 200 microns, APMPP is around 0.5 disc diameter, Azure has a RP atrophy. These multifocal choroiditis, birdshot choroidopathy requires treatment which is having a large size, but these four usually we can observe them. So when the patient we have a white dot syndrome, they can also have an enlarged blind spot. When we see enlarged blind spot, it can be because of the papilledema or unapparent disc swelling without any having a disc swelling, like we can see in something called as acute idiopathic blind spot syndrome, mutes, AMN, multifocal choroiditis, and Azure. These five are all something called as Azure complex. So coming to FFA characteristics of this white dot syndrome. So multiple evanescent white dot syndrome has a typical early hyperfluorescent wreath-like spots, which you can able to see here. So it's a wreath-like spots which are like more typical of mutes, and this is the only white dot syndrome which will be having a early hyperfluorescent lesions. Other all having a early hyperfluorescent lesions. So So, usually cystoid macular edema and peripheral leakage won't happen in the case of mutes. APMPP will have early hyperfluorescence with a late placoid and staining part of it which will be there. Azure will be having the early hyperfluorescence like RP staining which late it is still having it won't increase in the leakage. Multifocal choroiditis, any choroiditis lesion like thing, it will having early hypo with late staining. So birdshot retinopathy has something called as quenching sign, where the retinitis lesion is in the retina. There will be early wash off period for the fluorescence, so that in the by the time of 1 or 2 minutes the fluorescence has been completely washed out. Serpiginous choroiditis, again it will be having a early hypo followed by late hyperfluorescence. And there are like, it's not like every time you will get single entity. They can have multiple entities also, like where they can have a overlapping. For example, like in this you can able to see both multiple evanescent white dot syndrome along with multifocal choroiditis. So this is the FA of the picture. So they can have mutes with APMPP. You can able to see the fluorescent angiography picture also in this. They can be associated with acute macular neuroretinopathy. And there are certain diseases which can mimic as white dot syndromes, like DUSN, like the crop-like lesions what you see in the periphery sometimes. So these can get confused, but make sure to rule out any worm is there or not in these conditions. So another condition which we commonly missed is VKH, and which is usually most common differential diagnosis for APMPP, where in the APMP we see the late staining, but in the VKH we will see the late leakage. Sarcoidosis also sometimes can have this, especially in the inferior area, you will see multiple whitish choroidal atrophy, very small dots in the later stage, which may get confused with white dot syndromes. So, coming to the take-home message, usually acute idiopathic blind spot syndrome usually doesn't require treatment. There will be only enlarged blind spot. Azure complex involves the mutes, azure, and other conditions. Mutes has a typical evanescent white dots of 100 to 200 microns with wreath-like hyperfluorescence, and a diagnostic test to see any white dot syndrome is affected, how much is the extensive involvement of the retina. ERG helps us to see that. So female preponderance in mainly in all the conditions except in the APMPP and serpiginous choroiditis. Photopsias are classical of white dot syndromes, and the Shigal lens can be seen in multifocal choroiditis, which indicates it requires further immunosuppression. So quenching sign, as I told you, is a typical of birdshot chororetinopathy, and early wreath-like hyperfluorescence is classically seen in case of mutes. APMPP, there will be early hyperfluorescence followed by late staining, and in VKH there will be early hyperfluorescence followed by late pooling. So I thanks my mentor Dr. Avinash and GMRV campus to helping me with this condition. Thank you.
Basically, in this white dot syndrome, there are a multitude of etiologies. So our basic approach is that we have to rule out infectious causes before the non-infectious causes. So classically, there is not many causes which can cause the infectious etiology in the white dot syndrome, but sometimes you can have endogenous fungal endophthalmitis can have multifocal placoid appearance. Then sometimes tuberculosis and
syphilis is the other most important thing to rule out.
But it will not present as a multiple white dot syndrome. Syphilis very unlikely. So whatever the basic thing is that we have to rule out infectious causes, and once you have ruled out the infectious causes, we have to see whether the non-infectious cause, whether they are sight threatening or they are self-resolving. So anything which is affecting very close to the macula or causing significant drop of vision, they need steroid anti-inflammatory treatment. And in that non-infectious pathologies, whether they are having indications for immunosuppression. So if you have diagnosing VKH or birdshot, all those patients, they can have a very aggressive course with vision loss. So these are the patients which you have to identify from the beginning, and we need to consider starting immunosuppression right from beginning to prevent recurrences, relapses, and ultimately poor visual outcome. So this is the basic approach to white dot syndromes.
I want to ask one question. OCT picture is not there in white dot syndrome. It has no role, or
So it has a role. I just wanted to show how to differentiate the other white dots, all the white dot syndromes. Usually in the mutes, it has a classical something called as foveal granularity over the fovea. So when you see clinically in the mutes, you will see something called as small orangish nodule-like dots we can see over the fovea called as foveal granularity. And in the OCT, what we see is the ISOH junction disruption in that area. It's a classical of mutes. And in other APMPP and all, if you see there, there will be loss of chora capillaris and ISOH junction in the where is the localized area part of it.
so OCT angio and extended depth OCT
Yes, it
angio
is still it has especially in the case of APMPP in the OCT angio when we do we'll see the loss of typical localized loss of chora capillaris can be noted, and once we start treating, once it become we can see this recovering also clearly.
How you know that region is active or not?
Which conditions?
Which in all white
So one thing.
when to treat and when not to treat?
Usually the mutes and other mutes condition doesn't require any treatment. So to see the activity, we see whether especially in the case of multifocal choroiditis, it is an issue because they will be having a recurrent activation, and also APMPP sometimes they can have central nervous system vasculitis also can be involved. So we need to do MRI to rule out that. Classically, to see clinically, if the creamy yellowish lesion is noted, that means it is active clinically. And yes, FA, if you still we have a doubt, FA will show you disc activity, and the peripheral lesion activity also will help me to see whether it's active or not.
Any role of anti-VEGFs?
Only if there is a CNVN nowadays we give, especially in multifocal choroiditis.
Yes, if
So
there's
in
associated granuloma is there.
PIC
in such
patients
cases.
also, they have got a very high incidence of CNV.
Yeah.
PIC patients.
Big patients.
Yeah. So you can go to the next talk of artificial intelligence in retina.
Who will take this topic? Who has to present?
He's
Actually,
on.
he-
Yeah.